Okay, thanks so much everyone for coming. Today I'd like to present really 3 studies. You get 3 for the price of 1 today. Readmissions in patients with heart failure. I want to tell you about some work we've been doing on predictors, patterns, and some of the associated controversies in measuring, which will hopefully become apparent. It's come out of NIHR project, and some of the analysis has been done by my colleague Rosalind over at Dr. Foster Unit, and particularly the count models. And Paul and Derek have also had input into this on the clinical side. So, as you know, failure is unfortunately a fact of life. It is everywhere at the moment, particularly for followers of the England sporting teams. But it's the one on the right that I'm going to talk to you about today. I'm very happy to spend hours talking to you about the other kinds as well, but let's leave that till tonight. So I'm going to tell you about heart failure, just a bit of background about heart failure and the sort of associated morbidity. And the issues are about how should readmission be measured. It's had a lot of coverage in the last few years with paper performance schemes, for instance, and quality improvement generally. So it's important to try to understand what drives readmission rates. So we're going to be looking at 3 studies looking at different aspects of this. And obviously I'll give you a bit of methods and a bit of results for each and try and summarize them at the end. And obviously some questions lead inevitably on to further questions, and hopefully you'll have some of your own as well. Here's a potted summary of what heart failure is. It's when the heart muscle is too stiff or weak to kind of pump out enough blood properly. There are lots of causes of this, particularly coronary heart disease, hypertension, valve disease, atrial fibrillation, overuse of alcohol, various drugs, etc., etc., a lot of causes. And it's very common. So it's estimated there are roughly about 900,000 patients in the UK with heart failure, many of them elderly. And it's a worldwide problem as well. It costs a lot of money to treat these folk, at least 2%, for instance, of direct NHS costs. And GPs amongst you will be familiar with these patients. NICE reckon that a GP has on average 30 such patients, and suspects a new diagnosis of heart failure in another 10 or so each year. It's a chronic condition, but it also has very high mortality, and with big variations around the world. And there's also a lot of variations in quality of care as well. So there's a national audit on heart failure in England and Wales, and that's found a number of differences in terms of care quality and outcomes, both by hospital but also by ward. So for instance, if you're seen in the cardiology ward or not. And we're interested in readmissions partly because many of them are considered unnecessary or avoidable, but as we'll see, it's actually pretty difficult to prevent readmissions, or at least some of them. So, as I mentioned, the NHS sees a lot of such patients, and it sees them in all these different elements of the NHS. So GPs amongst you will see a lot. Some of them go up to A&E. There are 60,000, 70,000 admissions per year for heart failure patients in England. A lot are seen in outpatients, and obviously it's not actually a part of the NHS, but there's a high mortality as well. So let's look at readmissions in heart failure patients specifically. Heart failure admissions are rising due to ageing, and so readmissions are therefore going to go up just by ageing population. And the evidence suggests that lots of these are avoidable, and because there are issues in, say, discharge planning, medication reconciliation, maybe gaps in primary care. So there are hospital level elements to this, but also sort of post-discharge transitional care interface issues as well. As I mentioned, it's gained a lot of traction, a lot of publicity, partly because of, in the States, there's now the Center for Medicare and Medicare Services, CMS, now have pay-for-performance schemes. So hospitals get penalized quite a lot of money if they have high all-cause 30-day readmission rates for heart failure, but also AMI, pneumonia. In fact, the list is growing each year. But why 30 days? Why should CMS use 30-day cutoff, for instance? Well, there is no biological reason for that. And there's also no neat cutoff that says, at this point, readmissions are preventable, and after 30 days, they're not preventable, for instance. And you can argue that the shorter the follow-up, the more likely the issue is to relate to the hospital than to, obviously, post-discharge care. So there's lots of trade-offs going on in terms of the time period. So we'd like to explore different choices of time period. So next issue is, well, why all cause? Why combine all cause of readmissions? Well, the advantage is, of course, you gain statistical power. It's patient-focused in a way. The patient still ends up back in hospital. It's still it's a big event for them. But in terms of quality improvement, you could argue, well, what do you lose by gaining all causes? People are readmitted for all sorts of things. And as we'll see, we find you could lose potentially quite a bit of useful information for quality improvement in that. So that's going to be a theme of the talk, as you'll see. So are readmissions avoidable? If they're not avoidable, there's not a whole lot of point in trying to do quality improvement projects to try to reduce readmissions. So here's a fairly recent high-profile study that's trying to look at 6-month readmissions in 11 hospitals for various types of adverse events. And this study by Van Welraven et al. Has reckoned that 16% of readmissions were classified as preventable. And they tried to correlate the proportion of readmissions that were deemed preventable with the overall readmission rate among these 11 hospitals. And the correlation was modest, but not statistically significant. Well, you've only got 11 hospitals. Of course, you're not going to find anything significant with 11 hospitals. And the other main limitation is that, of course, the reviewers differ in terms of deciding, well, was this readmission preventable or not? And there's also a cut-off, really, in terms of preventable. Preventability is obviously a scale. It's not neatly yes, no, preventable, not preventable. There's a lot of parallels with the recent controversy over avoidable deaths in hospital, which I can talk about later. But readmissions, in a way, is kind of a similar kind of thing. So this study was has some major limitations which really prevent us from getting at the answer properly. But it's a good start. So that's readmissions in general. What about readmissions in heart failure patients? Well, clearly the CMS thinks so, otherwise it wouldn't have had this paper for performance scheme. There are also a lot of studies that show a link between inpatient and outpatient processes of care and readmissions. There are a number where they haven't managed to show a relation, but they're enough to suggest that actually, yeah, there's a big chunk that probably are preventable. And in terms of transitional care, I came across just the other day a systematic review meta-analysis of a number of clinical trials of transitional care. And this suggests that home visiting programs and multidisciplinary heart failure clinics were able to reduce all-cause readmission rates by about a quarter. Also reduce mortality. And there's some evidence that suggests that structured phone support, although not telemonitoring, also reduced heart failure-specific readmissions. So it seems that there's quite a bit you can do to reduce these readmissions, but it's not easy. So let's go on to our 3 studies. We wanted to know what are the patient-level predictors of readmissions heart failure patients to try and understand patterns better. I mentioned time period of follow-up earlier, so are the predictors for 7-day readmissions the same as for 30-day and for 365-day readmissions, for instance, or do things change? Does it vary according to the main diagnosis of that readmission, whether you're readmitted principally for heart failure or readmitted principally for one of the various other things you probably have wrong with you, COPD or whatever? And a methodological issue here is, do post-discharge deaths get in the way? So clearly, if you're discharged and then you die, that's the end of your admission history. It's the end of many more things in your admission history, obviously. But you then cannot be readmitted after that. But analyses of readmissions generally just ignore that fact. They wave it away and hope it doesn't matter. But in a condition like heart failure, you've got a lot of these kind of post-discharge deaths, so it may get in the way, and there are statistical methods for looking at that. We had access to some audit process of care figures from the National Audit 2011, so do they correlate with the measures? And if so, which ones? And then lastly, do these count models, which are kind of more sophisticated models, do they tell you anything else beyond what the basic yes, no, readmission models? So those are our questions. Study 1, we looked at we divided in a set of patients whose first ever heart failure admission occurred in a couple of years. By first ever, I mean we tracked back in 10 years and excluded anyone with a heart failure admission in those 10 years. You then track forwards in time in the data, and you get the next admission and the date of death. Follow up for 365 days and then stop, and then you define these various readmission yes-no measures. And we've split them into those for heart failure, which are these, and those for any other primary diagnosis. The analysis was fairly straightforward. Logistic regression to find the predictors of the readmission and split by diagnosis on readmission. Compare the results by time, compare the results by diagnosis. And also, to amuse myself, compare it with these couple of fancy methods that deal with the post-discharge deaths thing. We looked at these covariates, age, sex, deprivation, a range of comorbidities as suggested by the literature. The length of stay, the index admission. Lots of people wonder about the kind of rotating door. Does short length of stay lead to higher readmissions? And HES has got outpatient data nicely attached. So I looked at the number of outpatient appointments that they had attended in the previous year and the number that they had missed in the previous year. And we also looked at some procedures: heart bypass, angioplasty, defibrillator implantation, cardiac resynchronization therapy, and other kind of pacing. So the results of the first study. We had 84,000 patients, 16% died, leaving us with 70,000 patients. And then a bunch of those, of course, died during the year of follow-up. So overall, 40% of patients died within 1 year of their first heart failure admission. It's pretty high. And it's also higher than literature from other countries as well. So generally, our readmissions rates are lower than in other countries, but our mortality seems quite high, actually, compared with other countries. Half got readmitted within the year of follow-up. Comorbidity was very common. And lots of the readmissions were not for heart failure, or at least that wasn't their principal diagnosis. Only a third of them, and that fell over time. So it's related to this fact. People got readmitted with diabetes and COPD and all sorts. And this slide essentially shows the same thing, really. The proportion of patients who are old, and in fact very old, is very high. And contacts with the health service also very common. So half have had at least an emergency admission in the previous year. Lots of them have missed appointments in the previous year as well. And comorbidities, pretty common. Lots of other kind of heart disease, diabetes, lung disease. So these are old, sick people. And here are the results. And I've split the odds ratios by those for heart failure and those for where the readmission is not for heart failure, it's for something else. Some things are kind of predictable, older age, deprivation. But perhaps this is kind of interesting. The number of previous outpatient appointments that they had attended has a little, this is per appointment, there's little relationship with non-heart failure ones, but what's more important is the number of appointments that they've missed. So per appointment, you get an extra 5% or 10% odds of readmission per appointment missed. And some of these folk have missed a lot of appointments. Another thing, a couple of things to mention here is that some of these comorbidities are associated with readmission only for one of the two causes. Some are for both, but some, like this one, the arrhythmia, is only associated with heart failure readmissions. Other thing to point out here is the impact of length of stay. So compared with same-day discharge, there's those with longer stays have lower risks. Those who are in and out on the same day had the highest readmission rates. So one of the reviewers of this for this study asked, well, are these actual readmissions or proper admissions if you're in and out the same day? Isn't that just an A&E attendance miscoded? But these folk had the highest readmission risk of all. So it actually suggests that they're not inappropriately there. They are real admissions. They're just probably not in for long enough to be able to assess them properly. And this makes the point about the impact that length of stay has. So here's for 7 days, the impact length of stay and longer length of stay is actually a good thing compared with staying 0 days, but the effect diminishes with time. And for non-heart failure, it's less. So it's a stronger effect short term for heart failure readmissions. It's a little bit complex, but that's in essence what it is. So in summary, study 1, post-discharge death doesn't seem to invalidate this approach, which is good news, because all studies ignore that problem, so it's a relief that it's not a problem. The predictors, apart from length of stay, as I mentioned, were the same over time, so that the table I presented was just for 30 days, but it actually doesn't matter if you look, in terms of the predictors, whether you look at 7 days or 365 days. Very short index length of stay looks like a bad news. There's a little bit of revolving door for those very short length of stay folk. Some predictors differ by readmission diagnosis. And if you've missed an outpatient attendance before, then that's quite a strong association with readmission. So that was patient level. Next up is hospital level correlations. So given that, as we've seen, some of the readmission predictors vary by the readmission diagnosis, and most readmissions in heart failure patients are actually for other conditions, we wondered, well, let's split the hospital readmission rates and look by the diagnosis and see if there's any correlation between two. So do the hospitals with high readmission rates for heart failure also have high readmission rates for other conditions, or is there nothing at all? And which of those two kinds of readmission rates correlates with the process measures from the audit? So this time we used 3 lots of index years of index admissions. Again, we looked at 7, here we just looked at 7 and 30-day rates, split by diagnosis just as before. And we had the 2011 audit results for 124 hospitals, so that's about 3/4, 4/5 of them. And we just looked at some correlations in the usual way. And here is the distribution of readmission rates by hospital. Here's a funnel plot. So this is for 7-day all-cause readmissions. The other two, split by diagnosis, look just the same, kind of same pattern. So you've got number of patients along here, and you've got the risk-adjusted readmission rate up here. Each dot is a hospital, and we've imposed 2 and 3 standard deviation control limits over the top. So with 150 hospitals, you would expect maybe one hospital to lie outside, no, up here or down here, and you've got, well, there's one there, there's a low one there, and there's a high one there. And you'd expect maybe 7 or 8 hospitals to lie outside the 2 standard deviation limits, i.e. above the blue line or below this blue line, and you've got a few more, a bit hard to see on the screen, but you've got a few more than that. So it's a bit more variation than just by chance, just random variation. That's 7 days. 30 days, it's the same kind of pattern, essentially. So is there any relation between readmission rates for heart failure and readmission rates for non-heart failure? And the answer is a little bit within 7 days, and not really within 30 days, and definitely not within 365 days, which I thought was mildly interesting. So which of those 2 flavors of readmission rates correlates with the process measures? So the process measures on the audit, we've got a couple of drugs. So there's some prescribing issues. Well, there's in fact 3 drugs, beta blockers. We've got referral to cardiology as for follow-up. We've got whether they were treated as a cardiology inpatient, did they get echocardiogram, and were they referred to heart failure liaison team afterwards. So we correlated the proportion of patients with each of these things with the readmission rate. And you can see that at 7 days, they all correlate as expected in a negative way, but weakly, with heart failure. Some of them do at 30 days. So there's a suggestion that if you perform better on these, you will have lower readmission rates, assuming causation, of course. Whereas the readmissions not for heart failure, for some other primary diagnosis, nothing really. Not much correlation, either 7 or 38 days. So I wondered whether this is one reason why a number of studies have not been able to show relations between quality of care and readmission rates, because they tend to use just all-cause readmission rates, because this suggests that the pattern is actually quite different depending on the cause or the primary diagnosis of readmission. So a couple of points for study 2. As I mentioned, the funnel plots seem to show a bit more than random variation, a few more outliers than we'd expect just by chance. The 2 sets of readmission rates correlate only weekly and mostly really only at 7 days. After that, there isn't really any. The care processes, the prescribing, etc., they only really correlate with the heart failure readmission rates, mostly at 7 days, and they're quite weak as well. So to me, and we can talk about this, all this is consistent with the theory that there's really an important role for primary care, particularly beyond 7 days, because as the hospital impact, if you like, diminishes, then there's a role for post-discharge services to pick up the baton. So that was a potted history of studies 1 and 2 looking at readmission rates. Now I want to talk about count models. So I had done very little of this before really started this study, and Rosalind's been having a lot of fun playing with these, and these are quite, actually, they're quite interesting in a way. So what did we do for this bit? Well, the previous bit showed that 30-day readmission models are quite low discrimination. They're not that good at predicting who's going to be readmitted and who isn't. And there are lots of potential reasons for that, which we can think about afterwards. So one question is, well, do these count models do any better? By a count model, I mean instead of dividing people into yes, no, were they readmitted or not, can we count the number of readmissions that they had in the year after and predict those? And can we count the number of inpatient bed days that they're going to have during that year? Because that might give us more information. We're not throwing away so much of the data by just dichotomizing readmission into yes, no. So those are the count models that they try to predict the number of readmissions or bed days. Another reason for looking at these is that readmissions are really common, and some folk have a lot of readmissions. We're not meant to call them frequent flyers anymore, but you know who I mean. So we wanted to compare the usual 30-day readmission rates outcome with these count models. Also these so-called bucket models from economics, where you divide patients up according to into, say, 5 buckets of resource use, from high to low, where you've got each bucket, or each, say, quintile, you've got the same number of total admissions covered in each readmissions in each bucket. So you're looking to, can you predict who is going to have the highest resource use measured by either the future readmissions or future bed days. So that's what I mean by a bucket model, because it puts all the patients into buckets and tries to predict resource use bucket membership. Same 3 years of index admissions, and we've got so the usual thing: first readmission within 30 days, and then the number of readmissions within 30 days, 365 days, the number of bed days within the year follow-up, and whether they had the highest resource use, whether they're a member of one of these top resource use buckets. Just looked at unplanned activity. There was some elective activity, but we've just ignored that, fairly minor. And here's a brief technical bit. We obviously did logistic regression for that and the buckets. And then we've got Poisson and negative binomial models, including inflation for zeros or not, and these so-called hurdle models, or not, where you divide the outcome into kind of 2 bits really. So first task is to predict whether the patient goes on to have further readmissions, yes or no, and if they do have further readmissions, how many do they have? So that's like an extra bit of the modelling. The statisticians amongst you will presumably know this and enjoy these kind of things. There's not Anthony here. He wasn't found out. Yes, you did some of these with your bus bus use as well, didn't you? Yeah. 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 So you kind of split the people, the zeros, into those who will always be zero. So in your bus use, the people who will always be zero will be, for instance, obviously those who die and are never going to use a bus, or those who have some kind of weird allergy to using buses. Maybe they have a grudge against the bus company. Maybe they were sacked for drink driving while as a bus driver, and therefore never going to use a bus again. I mean, there are all sorts of reasons why you would definitely never use a bus. So those are they're always 0. Then you've got the possibly zeros where people who only use a bus occasionally and in your study period, they just haven't used it. So you apply the same idea to hospitals. You've got the people who will always have 0 readmissions, such as obviously those people who die or people who move away out of the country and so don't appear in HES. Or you've got the possible zeros. Hence, you've got these hurdle models can kind of get around this. They use 2-stage. We've got to have about 100,000 patients for this bit. A quarter of them died during the following year. Readmissions mentioned was really common. About half of them had an emergency readmission, including a big chunk of subsequent readmissions, not the first one, but second or 2 or more readmissions, and about 120,000 overall. Half of the bed days were in the first readmission, so obviously that implies that if you only consider the first readmission, you're losing half the activity in the year. And only 1 in 5 were heart failure, as I've mentioned earlier. So of all these models, which of them fitted best in terms of trying to predict the number of emergency readmissions that people had? So our target is the light blue, the observed. So that's how many people actually had. So you can see a massive chunk had 0, just under 50% had none. Then you've got the rest having 1, 2, 3, 4 more, a few even having 10 or more. So that's what we're trying to predict. The easiest thing is to just fit a Poisson model, which turns out to do pretty badly. It's too low there, it's too big there, it's too big there, it's too big there, it's a bit rubbish. Whereas these other ones, all these other various fancy ones, are in general much better, particularly some hurdle models. So all those other ones, they tend to fit better for number of readmissions. And if you try to predict the number of bed days for in the year after discharge, then again we're trying to match the light blue colour. Here's the Poisson in dark blue, absolutely useless, whereas the other ones do relatively well. So these count models fit the data fairly well. So what do the results actually tell us? Now, there is a massive table that I could show you, which has all the coefficients and all the different parts of the models and all the models all lined up. But I thought what I would do instead is to give you one slide just to illustrate what these count models can tell us. Still a little bit complicated, but at least it's only one slide. And it suggests, for instance, that the young people, they are more likely to have no readmissions or bed days, but if they are readmitted, they're more likely than older folk to have multiple readmissions. So you can't get that information from the standard yes/no. The older, on the other hand, are likely to be readmitted only once, but not more than once. But on the other hand, they're more likely to be in the high-use bucket. So how do you get to belong to the high-use bucket? You can either have lots of readmissions, or you can have one readmission that lasts for months. And it turns out that the elderly, since they're not likely to have lots of readmissions, but they are in the high-use bucket, that means that they've got one long readmission rather than several short ones. Whereas the young is kind of the other way around. So you can't get this kind of information from just the standard readmission models, but you get vaguely interesting things like this. It's a different way of looking at and kind of tease out the patterns. Who gets admitted, how often, how many times, and how long do they stay kind of each time. So that's age. There are other results in here. So, as you might imagine, some comorbidities are kind of bad for you, whichever outcome you look at. Renal disease, pneumonia, mental health diagnoses are associated with a higher risk of any of these outcomes. Also, prior outpatient appointments, but particularly how the number of prior outpatient appointments the patient had missed. And that was quite a strong predictor. We saw that earlier with readmission, but it's also the same for these count models too. And various comorbidities, deprivation, living alone, were also associated with having multiple readmissions. The 0-day index length of stay, if you remember, that had this, would put you at higher risk of particularly short-term heart failure readmissions. As we know that increases your risk of a single readmission. But it turns out that those who have long index stays go on to have long future stays. I mean, that's in a way it's kind of obvious. If you stay long once, there's presumably quite a lot wrong with you. Therefore, you come in again, you're going to stay a long time again in general. So, here's a brief summary of the 3 studies. Hence, I've got 3 bullet points, 1 per study. Bit of a squeeze, but here we go. So, study 1, some comorbidities have different associations with the readmissions for heart failure than readmissions for non-heart failure. Whereas the length of follow-up, the time to readmission, doesn't really affect the results, and luckily post-discharge deaths, again, don't seem to affect the results. That was study 1. Study 2, we saw on the funnel plots that this is hospital-level variation in readmission rates. They're not quite in control, i.e. there's more variation than expected, so it's not just random noise when you look at readmission rates in these folk. There's a bit more variation than expected. There is only modest correlation between readmission rates for heart failure and readmission rates for other primary diagnoses, and that's only there if you look at 7-day readmissions. By 30 days, it's gone. So there's something quite different really going on by 30 days. And the process performance, in terms of the prescribing and the use of echo, etc., that only correlates with readmissions for heart failure. It doesn't correlate with anything else, readmissions for any other cause. Which suggests that, given that these patients have a lot of comorbidities, they need more help with those. And study 3, as we've seen, the count and the bucket models, they perform a bit better. So in terms of fitting the data better and explaining a bit more of the variation, they do fit the data better than just this one-off yes/no 30-day readmission that everyone uses. And they tell us some useful extra things, like the age and length of stay I mentioned, but not millions of extra things. So it's quite a lot of work, and you get a bit for your extra investment in time and effort, though not masses, but some. So I think it's my last slide. There are a few extra things you can do with HES. So we saw that outpatient appointments did add some value to analysis. But that was all looking at outpatient appointments before the index submission. But so if you look at them after the index submission, so in terms of how patients are followed up after their index heart failure mission, and try and relate that, see if that relates to outcomes, that might be worth doing. So for instance, was the patient followed up, seen by a cardiologist in outpatients, or were they seen by general medicine in outpatients afterwards? The suggestion from the audit is that cardiologists have a key role in following up, as we saw the correlations earlier, plus their report. So that would be worth doing. The A&E attendances, we've not used those so far, but yeah, some of you know that have been playing with these data. They've improved a lot recently, so they will be well worth a look. So it might be worth looking at, say, the conversion rate, for instance, to see whether that has an impact on readmission rates. Or whether the time of day, so the time of day or week when you, the patient, turn up to A&E, and suppose how busy it is, does that have an impact on your chances of being readmitted and therefore driving the readmission rates? How much is that important? So that might be worth a look too. In fact, I wrote a grant to try and do that, but we'll see how that gets on. But it might be worth doing that before. And then another thing, with all these different kinds of NHS contacts, what about looking for, quite, if you like, clusters of patients? Can you identify different clusters of patients using from their NHS contacts? So are there some, is there like a subset of high users that drive the variation in readmission rates or not? That might be worth a look as well. There's just some things I thought of. There are millions of others you could do. So in conclusion, some predictors differ by the readmission diagnosis. Heart failure readmissions don't really correlate with 30-day non-heart failure readmissions, and processes of care only really correlate with heart failure readmissions. So the take-home message from all that is, if you combine the causes of readmission, you're going to lose a lot of information, particularly for quality improvement purposes. For the CMS, or pay for performance scheme, that's a different scenario, and it's probably okay for them to look at 30-day all-cause readmissions. But if you're doing quality improvement, I think you lose too much information that's useful here. HES has socioeconomic variables. You know about classes, etc. But here it's another coupled. So you've now got the non-attendance in outpatients. That looks useful. And there's also an ICD code for living alone, which we found was a predictor of various outcomes. That looks useful as well. And I'm sure there are others if you dig around. But of course, I've not really mentioned primary care activity in all this because HES doesn't do it. But CPRD does. So it would be really nice to link all the bits together and be able to really see properly what's going on. And that is it. Thank you for your attention.